say, as you know, I had a daughter who did a year of interferon, and I was very, very worried about, the side effects. This is a really active, healthy girl. And the first day, it was just suddenly, a few hours after she had that first injection, just moaning, crying, my body hurts, high fever. I thought, this is going to be a really long year. And the next day, she was up, going, and she was only 3, which I think maybe made it a little easier because she didn't have a lot of demands on her time, like with school and things, but she did need an afternoon nap every single day. But other than that, and occasionally we kind of complain of achy tummy and things, but no one ever would have guessed that year that she was on anything. She really seemed totally, completely fine.
Have you guys seen the video that Maya and Eileen put together? It's been on the, is it still on the website? It's worth a look. It brings tears to my eyes every time I see it, but it's great. Yeah.
Now, can you repeat? Interferon say it doesn't work, and then down the road could be used again, or once you use it, that's it?
No, you can use it, absolutely. Then it depends on the situation. Was it a relapse after termination of therapy? Did the individual not respond to begin with? What are the permutations of the situation? Because although it can be done again, it can be safely done again, the question really is about, is it going to work? And if it didn't work the first time, there's a higher likelihood it's not going to work the second time. However, times are changing, and the individual and their response to, or lack of response, is very important to consider.
I'll interject there. Just, it's everything you said is absolutely correct. But when you treat a 3-year-old and a 14-year-old, they're in such different immune states that you could get a very good response in a 14-year-old that just a 3-year-old with a really high DNA count wasn't the right time. So don't lose hope if it didn't work.
Have either of you used it off-label, pegylated?
I'm sorry, say again?
Have either of you used pegylated interferon off-label, and what was your experience?
Eileen, have I used pegylated interferon?
And her experience, and Maya cleared, she was genotype C, and I went to this conference, I looked at all the data beforehand. As Dr. Murray knows, we had a lot of conversations about, well, what's the likelihood of this working, and it's been a couple years now she's been done, and she's surface antigen negative, has surface antibodies, and yeah, so it was.
And were her ALTs elevated going into it?
Yes.
Yeah.
Yeah. And they had been, the whole time.
Were they really high, or?
When she started, she was at 100. So I don't know.
Higher than that before?
She'd been higher, but still not like, super sky high, but like up close to 200. And then on interferon, I think it got up to like 600 ALT on interferon.
All right, so those are the interferons. We can talk about more of the interferons later. I'm going to switch gears and talk about this other group of drugs, the nucleoside analogs. So the interferons have side effects. We've talked about that. The nucleoside analogs came along really in response to the yuckiness of the interferons and trying to find a better tolerated drug that was effective against the virus. And as the years have gone on, the drugs have gotten better, and I'm going to share that with you. What we have approved for children, as I said earlier, is somewhat limited, but nonetheless it is what it is. So much like the dawn here of Seattle, there's Mount Rainier in the background. This is sort of the dawn of new drugs and the nucleoside analogs. I like my analogy. It's corny, I know. Okay, so here are the drugs we have available for children with hepatitis B. Lamivudine was the original one. I will share some brief data with you. Adefovir came along subsequently. I think Barbara and I were both involved with those trials. And Entecavir has been approved, but for young adults for over 16. There is currently an Entecavir trial that is going on in children down to age, I believe it's 2. And I am not part of that study, but I'm assuming the preliminary end of treatment response data will probably go to press, I would guess, within a year. Were you involved?
Yeah, it's still going.
Is it still recruiting?
Not recruiting, but you can be treated for a number of years.
All right. So I guess it'll be a few years.
Still recruiting.
Still recruiting?
Yeah,
So-
staff's still recruiting.
Okay.
So we'll talk about these. So as a group, these are orally administered, they're once daily, they're very well tolerated. Although each one has slightly different side effect profile, really they're all very close to placebo, so effectively no side effects. We do monitor, clearly we monitor for virus response, and that is at least every 3 months, if not more frequently at the very beginning. But then I tend to, since I'm a product of interferon, I tend to watch some safety. I want to know if the transaminases are going up, what's happening, so I tend to get blood counts roughly every 6 weeks, every 3 months at the least. So these are adult data, and these are hot off the press from about 3 weeks ago, presented in Barcelona at the European Association for the Study of Liver Disease. And these are adult data, but they are comparative that I thought was worth illustration, so you could get sort of a lay of the land of response. So these were in e-antigen positive individuals who were treated with it for a year with either one of the nucleoside analogs or with peg interferon, which is approved for adults. And then 6 months later, they looked at the response. So this is the 6-month sustained response off the drug after a year of therapy. And here are here's peg interferon. And I just going to draw your attention to these last 4 columns, these last 4 rows. So the e-antigen rate of conversion, it's not dissimilar to what I showed you earlier. It varies on the genotype, and that was not broken out in this table. But it's in the roughly 30% range. DNA loss was not so good, but the ALT normalization paralleled the e-antigen loss. And look at the surface antigen loss. In the pediatric interferon study, it was 10%. In the peg interferon preliminary data, according to genotype, it varied from 2 up to 14, and here we are at 7 and 3. So here's lamivudine, and here's adefovir, the 2 nucleoside analogs that we have approved for children. So if we look at e-antigen seroconversion, they're relatively low. Let's be optimistic, call it 20. DNA loss suppression is a little bit higher, especially with lamivudine. In many trials for adefovir, it's actually higher as well. Surface antigen loss, not so good with this drug, certainly in comparison to PEG, but not 0. And then ALT normalization tends to parallel what's going on in the other areas. So these are the adult data with nucleoside analogs. I do have a slide in a moment for the pediatric data, which I'll show you, but they're not dissimilar. But what I really want to draw your attention to are the not yet approved for pediatrics, but nucleoside analogs for adults that are the newer generation drugs. So take entecavir, for instance. Tenofovir, I'm not going to talk about lamivudine. So here's entecavir, here's tenofovir. Look at the ALT normalization rates. Look at the DNA suppression of these newer drugs. These are newer generation nucleoside analogs. They have increasing potency. And so they suppress the virus better than our original drugs. And this is important, and I'll show you why in a little while. Similarly, relatively low surface antigen rates. Ooh, let me go back up. So if you speculate, so if you have a high with these drugs with really any of the nucleoside analogs, you get variable but pretty good suppression of DNA. However, as a group, the e-antigen conversion is not as good. And as I said way at the beginning, we would like to seroconvert e-antigen. We want to suppress DNA. But if we don't convert e-antigen, then the virus is still replicating. So we're going to withdraw the drug, and most likely the virus is going to come back up. So what we really want to do is we want the e-antigen to go away. We want antibody to come, which tells us that the replication is decreased. Does that make sense? All right. So in this case, this is 6 months after the end of 1 year of therapy. We've done a pretty good job at this moment in time suppressing DNA, but the e-antigen conversion really isn't very good. So what if we just treated for longer? And this is what happens in the nucleoside analog world. We say, well, treatment's a year, but it's really gray and fuzzy around the edges. So we consider continuing treatment. So what happens if we do so? So that's what's going on here. So we have our various nucleoside analogs, lamivudine, Interferon, entecavir, stelbivudine, tenofovir. And we have years of therapy. Now the lack of bars, for instance, tenofovir and entecavir up here, is not because they didn't respond. It's because at the time this slide was put together, these are newer drugs, we didn't have data for 3, 4, 5 years. Okay, but you can look at trends. So lamivudine in purple, entecavir in gray. These are in individuals who have had suppression of their DNA, but are still e antigen negative. How many positive? How many convert? How many lose e antigen, gain antibody in subsequent years? What's the percentage? So here we are in year 1. The bars tend to go up. It's sort of what you should be seeing. The bars go up. They don't go up sort of like rockets, but they do go up. And so with time, if you continue treatment, the DNA stay low, there will be, with time, more and more individuals that seroconvert. So that's kind of tantalizing. It's a well-tolerated drug. It's once a day. It's sort of like a vitamin. It's not hard to take. You should just continue treatment. All right. And for tenofovir and entecavir, again, you can see the trends. We just don't have data up here. All right, so that sounds good. Here are our pediatric data. That this is 1 year of therapy. E antigen, this is interferon, our approved interferon. The rates of clearance of e antigen. Here's lamivudine. Here's entecavir from those pediatric trials. You can see that. Here's suppression of DNA. Pretty similar across the way. Side effects, as I told you, interferon has some. Lamivudine and entecavir, for intensive purposes, do not. But then look at that. That was this new thing that came along, this new piece of knowledge that developed during our study and had just, was being better honed in the adult world. And that's this concept of resistance. So, the drug is on board, suppresses the virus. Drug is still on board, virus starts replicating, and the numbers go back up. The virus doesn't care, the drug's in its environment, it is resistant. And so at the end of 1 year in the lamivudine trial, it was 19%. And that's what we're seeing here. Here's the surface antigen clearance. So resistance, this was sort of a signal in that era of the timeline of this drug development that we were realizing that resistance to these drugs was a potential problem. And although resistance was not seen here with entecavir at the end of 1 year, we now know that there is a resistance to entecavir. So what contributes to resistance? Well, there are a whole bunch of factors. Certainly pharmacologically, the drug needs to be tolerated. You need to be able to get drug levels into an individual. And it needs to get into the tissues where the virus is. But really the most important factors have more to do with the virus itself, not the host. So what's the potency of that drug against the virus? How quickly can it suppress viral replication? So, and this is speaking to the DNA clearance rates and the e antigen clearance rates with time. If it's a drug that quickly can squelch the virus, then there's no virus to mutate and become resistant. Whereas if the drug is there and the virus is sort of hanging out, it has time to mutate itself and elude the drug's ability to suppress it. And then the viruses have different potentials, and we're learning a bit more about this having to do with the virus's genetics, what we look now at genotypic differences. We know, for instance, that entecavir and entecavir, so far it looks like the different genotypes don't affect resistance so much. However, for lamivudine, there are differences. So, for instance, lamivudine resistance, if you're genotype A, has a much higher potential than if you're genotype D, just as an example. How many genetic substitutions are required? How much mutation does the virus have to do to elude a drug? So on and so forth. So here are really just from a couple weeks ago again, in April, data looking into exactly that. These are adult data looking at lamivudine, entecavir, tenofovir, and tenofovir, and 1 through 5 years of therapy and the percentage of individuals who have resistance. So the pediatric study at 1 year was at 19, here's 24, they're effectively the same. As you can see, with increasing treatment, it's really mounting resistance. This is a problem if you're a 5-year-old and you're going to treat for a lifetime. It's a problem. So that's lamivudine. The other drug we have available is Interferon. It's better. It's the next generation drug. It is better, but it's not zero. And so, you know, folks like Barbara and I really think very strongly about what this means if we can't clear the virus with a given drug in our young people. We worry about it. And some of these mutations that occur, although it's resistance against lamivudine, you might say, well, we're just not going to use lamivudine again, but actually that same virus may also be resistant to one of the other nucleosides. And so we may be burning bridges. So the question is, can we have a drug where this is less of a problem so that it's potent, that the virus can't become resistant to it? And look at the newer drugs. We have much lower resistance profiles at this point in time. Tenofovir, we don't have much pediatric experience, although I had the honor of sharing with you for the first time some pediatric experience. But tenofovir really is looking quite promising, and entecavir similarly is very, very good, as you can see here. So, when Barbara and I and our others, and this is in the paper, one of the papers you have, got together and tried to make recommendations and give opinion about what we thought we most favored for children in general with hepatitis B. Again, individuals, you have to consider them independently. But based on the drugs that we currently have available, most of us felt that, you know what, interferon, it has some downsides in the short term, but in the long term was one of our best options. And most of us really liked the interferon as a class of drug. So that was our most favored. And then we have decreasing potency of the drug going from a higher favor to lower favor. And of course, they're approved for different ages, so it depends what age we're talking about. But that was our preference and thinking overall about treatments. All right, let's shift gears and talk about hot off the press stuff. This is kind of fun. Yes?
Before you do that, the chart where you showed the different percentages of how things worked with the interferon and all, the entecavir and the interferon, there was like a 21% and a 20.
You're talking about this one?
Yeah.
Or the resistance?
Yes, that one.
Okay.
So entecavir 20. Can you just tell me from a statistic 29 to 21? I mean, does that mean anything different?
Yeah, these are not side-by-side comparisons statistically, but usually those kinds of numbers they're typically not statistically significant. It depends entirely on the studies, but.
Okay.
So tenofovir. So tenofovir is one of the newer nucleoside analogs. As I say, I'm involved in the tenofovir trial. I'm not involved with the entecavir trial, and to my knowledge, there's not publicly available data. So these data were just presented 3 weeks ago, so they are in the public domain, and therefore I can show them with you. We do have a paper in hepatology that's been accepted and is not yet out that has a lot more detail. So this was a trial in children down to age 12, 12 to 18, who were randomized to either receive tenofovir or placebo. And they were treated for 72 weeks, which is a year and a half. And then they were treated for an additional couple of years with open label tenofovir. So the way these studies work, in order to know if a drug really works, folks can't be biased. If I know what drug a patient's getting, or the patient knows, believe it or not, that can actually influence the data, can influence the reporting. And so if you're really going to do a study with scientific rigor, then the individuals directly involved with the patient care, patient and the physician, shouldn't know what they're on. Someone does know what they're on. And if for some safety reason one needed to be unblinded, then there's always a mechanism to do so. The physicians typically get all the information they need to make safe decisions and know the safety of what's happening. But during the blinded phase, they typically are blinded to what the drug is and the lab data that would tell you what's happening. And that was the case here. So we were blinded for the first 72, and now we're in the open label phase. In the open label phase, everyone's getting tenofovir I know what they're getting, I see all their labs. And these data that I'm going to present are the initial end of the randomized period, the 72-week data. So there were 150 individuals screened, of which just over 100 were randomized to receive either tenofovir or placebo, and as you can see, they did so in a relatively equal way. And this randomization is not done by the investigator at the site, it's done by the overseers who are seeing all of the data, so that it is equal across sites, across patient populations, ages, etc. And then we treated for the 72 weeks. And of the individuals that started, the vast majority finished. So there was one individual that was taken out on the treatment arm for syncope, which is passing out, not felt to have anything to do with the drug, but the family did not want to continue participation. And in the placebo arm, there were a couple of folks that were taken out by the investigator because they felt that treatment, that things were not going as well for the patient as they would have liked, and they wanted to verify that the patient was actually on drug. They took them out of the study. Those are all appropriate. So I just have a couple of slides to show these data with you. So this is looking at the hepatitis B DNA suppression using two different thresholds, and those are the single and the dotted line. So tenofovir, looking at various thresholds of DNA suppression, and you can look at the percentage of individuals treated that actually had suppression. These are really nice numbers, especially when we're thinking about interferon, for instance. And then here's placebo. So there were a group that I didn't know wasn't on drug or was on drug, and they had, as we would expect, they did not have a response. Here's ALT normalization. So again, the tenofovir group, this is normalization percentage of individuals with normalized ALT. They all had elevated ALT at the beginning. As we treat with time, that number goes up, and as you can see, it's in the roughly 80% range here at 74. And in the placebo, there is some improvement in it as just the natural course of hepatitis B in some individuals, but it is lower at 31% in this study. So those are some preliminary tenofovir data, and as I say, your doctors will and you will be able to access hepatology in whenever it comes out, hopefully in the next couple of months.
Within that, did the E antigen versus the E negative respond differently? Who received tenofovir?
The answer is I can't answer that. Not because I'm trying to be difficult, but because we don't have enough data. So most of the individuals in this study, so there were a couple of limitations. Most individuals in this study, and it had to do with where they were recruited from, were genotype A. The other thing is that most individuals were E antigen positive. So to answer your question about E antigen negative, I can't do it. We didn't have the numbers. And it wasn't powered to do that. In other words, the study was not set up with that question to be answered. Otherwise, it would have been an E antigen negative study. So in pediatrics, the vast majority of kids are E antigen positive. And so when you do an open study, the vast majority of the patients you're going to get are E antigen positive.
I'm surprised about the genotype. Yeah,
Yeah.
why was that?
It had to do, this was a United States and European study, and simply because of regulations, the way the study was set up, where it was done, the vast majority of patients were actually recruited in Poland. I was the high enrolling US site at 3. So the most of them were recruited in Poland, and where genotype A is very common.
But to date, in adult populations, genotype hasn't really mattered for tenofovir, has it?
Correct.
Also, how elevated were the ALTs?
It had to be greater than 2 times the upper limit of normal, but sometime in the last 2 years. So the vast majority, and I didn't put that in here, but the vast majority actually did have an elevation of ALT at screening.
What would you say the differences between entecavir and tenofovir?
What are the differences between entecavir and tenofovir? Do you have something specific
Well,
you're
I guess I'm
questioning?
wondering how people decide to treat with one or the other.
Well, neither are approved right now, so most people don't treat with either. This was as part of a study. For children we're talking about.
Or for young adults.
For, I have that much experience with entecavir, so that's why I make my choice. But
Entecavir is great. Not to sell it, because I don't make it. But they're both really good.
They are.
The reason why this study only went down to 12 is because of the bone issues. So you don't treat young children with tenofovir. That won't be, that's why they
That's why
designed
this
the
study
trial
wasn't done.
was
Right.
designed this way.
So-
So they'll never go for lower age approval.
So, well, there actually are.
Are they?
Yeah.
Okay, never mind, I'm not in the tenofovir circle. But
So-
there were worries.
So, so your question is really, if you're treating someone who's 16 or older, or you're an adult with, and you want to use either entecavir or tenofovir, how do you make a choice? Well, as the next slide will show you, either is available, and maybe Tom can answer the question, how do you make a choice? I don't know how I would make a choice in that circumstance, but I also don't, I'm not in that circumstance.
I think it's
Bias,
personal.
your
Yeah, there's
personal
no-
preference. Well, you have more experience with?
Joan knows the answer.
Well, no, I don't, but I was gonna say, if you're talking about adults, I mean, I
Right.
think sometimes it comes down to the fact that tenofovir can be taken any time of the day,
Yeah.
before food, after food,
Right,
doesn't matter.
that is
And
on the bad
entecavir
side.
has to be
Yeah.
taken before you eat. Now, for most
That's true.
adults, that's a problem,
For most kids too. That is the biggest limitation of entecavir,
right?
is that 2 hours before and 2 hours after. So it's like, who doesn't eat?
So,
Yeah.
yes.
So it just comes down to, sometimes it just comes
Yeah.
down to lifestyle preference.
Yeah.
And insurance, not to be, but some insurance companies will pay for one and not another. Unfortunately, that's the reality of the times we're living in. And so that may very well influence a physician or a family's, bias as to which one they're going to use. So to address what Barbara was saying, so tenofovir is actually one of the components in Truvada, which is a 3-drug combination used in HIV. And in the HIV world, which Truvada with tenofovir in it has been used for quite some time, there are a lot of safety data, and there's also data against HIV, but there's a lot of safety data. And the two side effects that came up that were worrisome, so it's very well tolerated and all that, but the two that seemed to pop up in the HIV world were renal impact and bone mineral density impact for tenofovir. So renal impact, first of all, so the nucleoside analogs as a class, it depends on the dose of the patient and so on and so forth, but renal comes up for all of them. It's actually at the doses that are used, it's not usually an issue. But there's something called lactic acidosis. And as a class of drug, it's something that the physician will watch for and usually guide, if you're in the circumstances of extreme dehydration, yada, 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 you should stop the drug. And that's because of the renal impact and lactic acidosis. It just has to do with the metabolism of how the drug's metabolized. And that's true for the class. For bone mineralization and tenofovir, it's very interesting, and I am not paid by this company, although I clearly participated in the study. So first of all, in this trial, we did not find that the bone mineral impact met the threshold that we were, the outcome threshold. It did not mean it came shy to that. That having been said, there was a trend, and it was higher, the impact was higher than placebo, but it was not a clinically significant impact, it's just something because we were monitoring. In the HIV world, there is a real bone mineral impact. And it's thought it probably is a component of the drug which is used long-term in that population. HIV itself also influences bone mineralization, the virus does. So there are conflicting variables, and these individuals with HIV are on multiple other drugs as well. So we have confounding variables, but nonetheless, tenofovir is associated with decreased bone mineral density for the reasons primarily in HIV, also in some adult. Therefore, it was looked at in children. That was one of the big concerns. One of the study was set up to look at DEXA scans, which is a pretty detailed way of looking at bone mineralization at repeat time points to really scientifically and aggressively address this point. As I say, it didn't meet the threshold, but Barb was absolutely right. That's why it went down to 12. Also, Adefovir was approved to 12, and so there was a precedent for that. The tenofovir trial in children 2 to 12 is currently commencing.
I have two questions, and you probably can't answer them very well. So for E antigen conversion on tenofovir, you don't have any stats you can share
It's, as it's in the 20% range,
so far?
21, something like that.
And I guess this is for both of you in a real broad question of when you have a child on a antiviral trial or just for treatment, and maybe they seroconvert, maybe they don't, when do you stop antiviral treatment in a child, and under what circumstances?
So for the interferons tend to use them with a very finite length, so
Right.
depending which drug, 6 months or a year, we tend to start and stop, and write it on your calendar, the last dose. For the nucleoside analogs, the current recommendation for the ones we have approved is 6 months beyond e-antigen conversion. So we usually go into it saying, well, it's going to be about a year, but it's going to be gray. And then it depends what's happened. If the e-antigen has converted 6 months prior, then sure enough, we go ahead, and the DNA is gone, everything's gone. Go ahead and stop. If DNA is gone, ALT is normal, is what we're hoping for, but e-antigen hasn't converted yet, most of us will continue it. But here gets to speak into the anxiety we as pediatricians have, because now we're setting up for resistance, potentially with the current drugs.
But what has been your experience? Do the kids rebound when antivirals stop? And what has happened?
I have never stopped without seroconversion.
And is it
But I-
sustained?
Or resistance with
Or
hepatitis.
resistance is something,
Yeah.
like, as soon as you see on drug virus coming up, you,
Especially if the
nervous.
ALT comes up.
Does the seroconversion, is that
most of the
permanent?
time, we're both in clinical trials on these, so that, and yes, I've had off-label, but I pick my candidates, I guess, well enough that I haven't been stuck.
Yeah, and I actually have a similar experience. For the most part, if they get a response, it's been pretty durable.
Because I mean, that's obviously the
Right,
big
yeah.
question of why put kids on antivirals if there's such a risk that they'll be on them forever to suppress their virus.
And this, you are correct, and I mean, I can't speak to barbers, but,
Plenty have been
Most
on
of us-
2 or 3 years.
yeah. But many of us now, with the knowledge that we have now that we didn't have even 3 years ago, many of us are loath to start it,
Because the adults are
unless
on
we
it
have
for
good reason.
a decade, right? I mean,
So
Yeah.
did you say that the tenofovir pediatric trials will be starting from 2 to 12?
Yeah,
Because they felt that the bone mineral density issue was not
it's
as
acceptable.
Okay.
And they're gonna continue, you know, it's a study, so they're gonna continue to monitor for safety.
Is
But,
that going to
yeah.
be through your NIH trial or just?
No, it's Gilead is running.
Okay.
Gilead is who makes it up. So, just to move on for the sake of time, so these are recommendations that were put out by various groups. The American Association for the Study of Liver Disease it was in 2007, but updated in 2009. US Algorithm and ESA, which is the European equivalent, and this is adult data, not pediatric. These were the recommendations that were made. So, in all cases, elevated DNA, elevated ALT to varying degrees, with a biopsy, significant inflammation. And then these were the drugs that they had recommended, all three independent groups, tenofovir, entecavir, pegylated. Again, these are adults. They have a different armamentarium of drugs, but look, you see lamivudine and Interferon on here? No. So they are now second-line therapies in adults. So, you know, we as pediatricians, based on what we have approved, have a limited armamentarium. That having been said, there's a lot of research. And as I've tried to share with you, some of these better drugs for adults are becoming available for kids. It will get approved by the FDA, I have little doubt. And then it'll get approved probably with the young kids, assuming that goes well, and so on and so forth. So we really do, in the years to come, we have a much higher armamentarium. Yes?
So when we hear about mutations, that only impacts resistance, not maybe false negatives, thinking the DNA went down or the antigen went away when it's really there but different?
Basically, yes. That's correct. Yeah, you know, there's an exception to every rule. But yes, when we're talking about mutations, we're talking about genotypic changes, changes to the DNA, that affords the virus an advantage in its environment, which is usually in the setting of drug pressure. Something is forcing it to change. You know, so you force it to change. If you give it some elbow room, it will change. And that's with the earlier drugs that don't have the potency. That's what's happening because you're giving it a chance.
If your child has a genotype that is resistant to the interferon having a high success rate, does it make sense to think about doing a combo of nucleosides?
So the question is, if you have a genotype that is resistant to the interferons, does it make sense to do combination? I can't answer that question because we don't have data. We certainly don't have data in children. In the adult world, there are growing sets of data. We do know, for instance, let me see if I can get this right. We do know, for instance, that PEG interferon plus lamivudine is not better than PEG interferon alone. Did I get that right? I think that's right.
Yes, that's right.
However, with the newer nucleoside analogs, there looks to be not a synergistic, but at least an additive effect. I haven't looked at these data recently.
Well, let me say.
But we have very limited data, and then there is nothing adult or pediatric, there's nothing approved for combination therapy. So the reality is I can't really answer your question. So let me just finish up with sharing with you what the NIH is doing for hepatitis B. So for those of you who are not from the Pacific Northwest, this is the Hoh Rainforest, which is one of the few temperate rainforests in North America. And it's actually quite a beautiful place. And if you have been following the Twilight documentaries over the last number of years, you will know that it's inhabited by vampires. However, those of us who have spent some hiking time there have not seen one. There are werewolves in the area too, but I haven't seen them either. So the hepatitis, so NIH, and specifically a branch of the NIH that does liver disease, which is the NITDK, put together a research consortium now a couple of years ago with the interest of filling the holes in hepatitis B research that was not being done by the corporate world. And you know, there are a number of reasons to do that, but the most important is to advance our knowledge in hepatitis B and advance treatments in hepatitis B. Fortunately, the corporate world, namely drug companies, have in recent years, as you've seen, many of them have gotten interest in treatments for hepatitis B, and so they are improving, and these drugs are improving. But there are areas, there are groups of folks with hepatitis B that are not captured by these treatments, and that's what really the NIH is focused on. So they put this consortium together, and as you can see, it's both a consortium of pediatric hepatologists, which are listed on the right, and adult hepatologists from around the country, and all the little dots are from these sites. I feel a little bit lonely up here in the upper left, on the left. You guys most of you are from the east, as you can see, there are quite a few centers. And this consortium is looking at two different studies, basically. There are, in adults, there's an additional study as well. So in pediatrics, we're doing a cross-sectional study, a cohort study, or also known as a database study. This is an information gathering study. I'll show you the details of it. And you might say, well, information gathering, that we already know so much about the epidemiology and genetics, and actually we do. But there's actually a lot we don't know. And there's a surprising amount we don't know. For instance, let me give you some very simple answer. Most of us felt that it was the vast majority of hepatitis B in children that's immune tolerant. Most of us thought it was only the tip of the iceberg that had immune activity. What we've learned from this is it's only 40% in the study. So it is very high, but it's not as high as we might have thought. And those are the kind of information we're learning. Maybe more importantly, we're learning a lot about the genetics, answering questions about genotypes. We have very little pediatric genotype data. We're learning a lot more about that. Family members, how it was inherited, and so on and so forth. And then in the treatment world, the high, 40% of pediatric patients that are immune tolerant, so these are high DNA, E antigen positive, ALT normal. they are currently not served by the treatments we have available. And so we are, as a group, looking at, is there an effective treatment for this population to try ultimately to lead to e-antigen conversion, DNA loss, and hopefully surface antigen loss. And those are the two projects that we have going on. So for the cohort study, we're looking at natural history of hepatitis B. We want to know what determines e-antigen conversion. Once we know that, maybe we can influence it. We've set up a biorepository of not only data, but also serum, plasma, those are components of blood, and DNA, not to look at family genetics, but look at genome of the virus genetics. If an individual has a liver biopsy, as done for standard of care during the study, and there's extra liver tissue available that isn't needed for clinical decision making, we are storing down some of that liver tissue so that we can do testing on that as well. It's all about research. And then we're also developing more information to help folks such as yourselves and patients directly with hepatitis B. This study is actively recruiting at the sites that I shared, and actually in your packet I think is a handout that lists the sites that are participating in this consortium and the contact information. So anyone who's interested, you can't actively be on therapy at that moment in time. You can have a history of treatment. But if you're surface antigen positive, we'd love to have you involved. The immune tolerant trial is going to start up in the next couple of months, and similarly we'll be looking for participants. So we're hoping to recruit 250 children. The same study is being done in adults for another 250 individuals. For children, it's going to be 3 to 18. Individuals are going to be randomized for reasons that I told you earlier into two different arms. One is standard of care. These are immune tolerant patients. They have normal ALT. Our standard of care is not to treat. So they will continue observation as they would normally, and that's the bottom bar of standard of care. And in the treatment arm, they will be treated with 2 months or 8 weeks of Entecavir, followed by the addition of pegylated interferon. So combination therapy, to answer your question, but in this population, for an additional 40 weeks, for a total of 48 weeks. And why were these drugs chosen? Well, a couple of reasons. There are some preliminary data using the combination in very small numbers, so we never reached statistical significance, but to suggest that this combination could be effective in this population. And we want to know, is that really true or not? We think it might be, and we're trying. And then Entecavir has been trialed in young kids, so there are formulations of the drug. So this is a non-trivial problem in pediatrics. If the pill is a little tiny pill and can't be divided, and it's dosed for an adult, but you have a 5-year-old, how do you dose them? You can't slice and dice the pill to a fifth, even if you knew the appropriate dose. So that can be problematic. And besides, many young children can't swallow pills. And if it's a pill that can't be crushed, then you can't treat them because you can't get the drug in. And Entecavir has actually been formulated for use in young kids because it's been used in a trial with young kids. So that's another advantage.
When you have a trial, does the child need to be right there where the person can see them too? You can't do this remotely.
Yeah, this is almost always a limitation of these trials. So the reasons are a couple of fold. The drugs, especially during the randomized time, has to be dispensed, usually by a research pharmacy. And because I can't just write a prescription for Entecavir and peg interferon for the trial, the pharmacy brings down the pills. And in this case, they're not going to be giving sham injections. They're just not going to be on therapy. But so it's given by the pharmacy. You could say, well, you could mail the drug, and that's true. And in some trials, you can do that. The other issue is that for most trials, whether they're drug trials, database trials, treatment trials like NIH, they're usually embedding within them safety information, but also research questions having to do with genotype response, how much DNA, looking at other techniques for analyzing it. And so but they may not run those tests real time right there, and they may be tests that they obtain the sample, the blood, and then they mail to a central lab. And so, for instance, if there are 10 sites around the country, each lab has slight variability in what they do, how they do it. That wouldn't be very scientific. So we all collect our samples. Barbara collects samples in Philadelphia, I collect samples in Seattle. We mail them to a central lab who runs all the samples. We get very uniform information for our study. And it's to get that blood draw and ship it so it doesn't spoil and it gets there on time and it's done properly. It really needs to be drawn where the study is set up. And those are unfortunately limitations.
Do these kids have normal ALTs?
They do, they're immune tolerant. Yeah.
So is this only US based, or you can also be recruiting?
It's NIH, there is a site in Toronto. But other than that, it's good.
And can families choose, so if they want to, if they're most comfortable starting in the cohort, which is just the data collection, once they're in that, would they be able to move to the immune tolerant or not?
Actually, being in the immune tolerant mandates being in the cohort, not vice versa. So anyone, as long as they're not actively on treatment right now, can be in the cohort study. We would welcome participation. If you're 9 months of age or older, come on. For the immune tolerant, there's a little bit more selectivity having to do with age. You have to be immune tolerant. You need to be willing to be in the study. And, you know, like all studies, there's a permission slip with as close as we can get, as well as we know, full disclosure of what we think the side effects are going to be. But the treatments are provided. Peg interferon is very expensive. For a year, well, Riley's shaking her head, for a year of therapy, if you don't have insurance that pays for it, it could be $180,000. It's non-trivial. So these drugs are provided. Yes?
Well, I was just going to say, yeah, exactly, with peg interferon and with insurance is, our insurance initially said no, they weren't going to cover it. And I was shocked. I didn't know insurance companies would even say that. And I said, what? And they said,
say more than you know.
yeah, and they said, we'd like to see her on lamivudine, is actually what the person on the phone told me. And I said, but you're not a liver doctor. And so I asked if, they said, well, you could do this appeal, you could file this. I did that, and then they sent all of my daughter's information to another doctor to look over it, and then, and in the meantime, I said, well, how much does this cost? I'll just pay for it. They're not going to pay for it. And the person I talked to, they said it'll probably be about $1,000 a shot. You know, that's weekly for a year, and then in addition, you know, the blood work, and then my daughter wound up getting Neupogen, another drug injected during the interferon time, and they said that was about $750 like per shot. Anyway, it was. I was shocked, but then the appeal came back a week later, and they said, "Yep, we'll cover it. It'll be a $30 copay. It'll come to your house, $30 a month."
So good insurance.
Well,
Ours was covered too.
yeah.
Yeah, so, you know, there are clearly some downsides and limitations to participating in the study, in any study, but there are some upsides too. The monitoring is covered, the drug is provided, there are significant benefits. And, you know, you have to decide what's best for your child and your family. But I, you know, as an investigator, I think there's a real role. It's also how we advance our understanding of this. You know, we can't come up with new drugs and get new approvals and come up with new remedies if we can't figure out if they work, and figure out what the downsides are to them. Usually by the time they come to pediatric trial, they've been vetted in adults. We go into it knowing what the side effects are going to be. Maybe not the exact percentages in kids, but we know what they're going to be. We're not that cavalier. So the immune tolerant trial, the endpoints are as follows. We're looking at e antigen loss in combination with DNA clearance at week 96. And then secondarily, we're looking at those factors independently. So e antigen loss, seroconversion, DNA clearance. ALT is already normal. These are immune tolerant, but does it remain normal? And here are the thresholds that are being used. Surface antigen loss and seroconversion, which is surface antigen loss and antibody gain. We're looking obviously at drug resistance for reasons we've spoken about. And then growth parameters. These are growing children. And interferon does influence growth. It does influence appetite. And these are things we want to know about that's unique to children. So these are the pediatric centers that are participating. You have more details in your handout. You know, if you have any questions or otherwise, I and others would welcome any of those questions. So in summary, About 40% of kids with Hep B are immune tolerant, others are in various phases. Those with active disease are the ones that we're most worried about and the ones that we consider treatments for. Treatment options are limited, but they are expanding. And as I said at the very beginning, this is an exciting time in hepatitis B because we do have ever-increasing options available that have ever-increasing efficacies and safeties. And in general, there's a lot of research now going on with hepatitis B, and that's in large part due to the Hepatitis B Foundation. So with no further ado, I will stop.